Welcome everyone to another edition of paulhobra.com, where we have the incredible Frank Baetje from Germany, who is a bone specialist in terms of shockwave therapy. And some of you may have seen his webinar recently, which was frankly outstanding. I invited him to come on here. He's gladly said yes, and he's giving up some of his free time. I'm going to now ask Frank if he wouldn't mind just explaining a bit more about himself. Small biography for all of you. Frank, welcome.
Hi, Paul. Thank you for invitation. I'm a medical doctor, a physician since 30 years. I'm 60 years old, and meanwhile, at the end of my career, it was 1990 that I started my first job in Hanover, no, in Switzerland. But after 1 year, I changed to Germany. And then I continued my education, surgery, traumatology, gynecology, ear, nose, throat surgery, and so on in Germany for 10 years in different hospitals. And in 2000, I settled down as a general practitioner, not as a surgeon and not as a traumatologist, but as a GP. And that was the wrong decision, because after 1 week, the job was completely boring in my eyes. So, and then I returned to my roots that was emergency medicine, chiropractic, and surgery. And I was interested in the musculoskeletal system. And so I had a newspaper, a medical newspaper in my hands after 1 week of in my own office. And I read something about shockwaves, and that was for me the kickoff to invest in my first device. It was a cheap device. It was radial pressure waves. And I started without any experience 20 years ago with shockwaves, but it was, I had much success concerning the quantity of patients. Many people came. And from the beginning, I had a good network with other colleagues nearby. And so I started with the typical approved standard indications like rotator cuff and plantar fasciitis and achelodynia and so on, elbow, tennis elbow, and so on. And at that time, it was a nice coincidence that the hospital where I had my 10 years education asked me to collaborate with them with a new device. It was a urologic lithotripter from Storz Medical. And they asked me, do you have any idea how to use it for your patients? Yes, I thought I have a good idea. I read something about non-unions. I've never saw a non-union before. And then after 1 month, I had my first patient, and it was a big theater. It was in the operation in the operative theater, and we had to move all these clothes and to sterilize our hands. And so the workflow was very limited. So I had 1 patient each week, but after 1 year, it was 10 patients each month, for example. And then I had my first lecture with a specialist from Switzerland, organized by Storz Medical. He came to Hanover, and we had a lecture in front of 30 surgeons and traumatologists here in Hanover and from the surrounding. It was quite successful. After a couple of years, I had my next lecture with Wolfgang Schaden from Vienna. In my eyes, the godfather of shockwaves. And he supported me extremely, and that was the beginning of my main activities concerning non-unions and delayed unions. And since 2000 or 2001, I had now almost 3,000 non-unions, which I treated personally. It's a big quantity. To my knowledge, it's the second large data bank worldwide, I think, after Wolfgang Schaden's data bank. And yes, at that moment, it makes 50% of my routine work each day to care for non-unions and to treat them with shockwaves. People come from whole Germany because we are not so many persons who have all the necessary devices and these contacts to those who pay for it, for example. But my network seems to be quite good, and so I'm very busy with shockwaves each day.
Amazing story, truly amazing. And I know Wolfgang Schaden a little bit from being in Beijing last year. Very nice man and a worthy mentor. I agree with you. So tell us, what machine do you use now? Is it a Storz focus device? What machine do you use?
I have two devices. I have this big device in this hospital. It's a Storz Modulite SLK. It's a urologic lithotripter, but I use it alone because the Department of Urology of this hospital has now better possibilities to treat kidney stones. It is more an endoscopic treatment. And so this device is only for me. I use it each Wednesday and sometimes 2 times each week for a whole day. My patients, which I have seen a week or a day before, came to this hospital. We meet there and I treat them, sometimes 6, 8, 12 or 14 non-unions each day. That needs 8, 7 or 6 to 8 hours. And each session needs 45 minutes exactly. Usually I treat one bone because it's more frequent compared with situations where patients have different non-unions in her body. So normally one bone, one patient, 45 minutes, and sometimes maybe tibia and fibula, so 2 bones that lasts a little bit longer. That's for the long bones, a big device for long bones, because you have the C-arm to find the gap. You have a computer assisted navigation tool to identify the gap under the surface of the skin and to move your shock waves directly into the gap. So this is very tricky, but it makes a lot of fun. It's like computer gaming. And in my office, I have another device. It's a Storz Duolite SD1. And this office device combines focused shock waves with radial pressure waves and has an ultrasound. Without changing the device, I can continue the treatment directly after identification of my object. So 2 devices. So in my office, I have several Storz Duolites. And a couple of years ago, I was settled down in another clinic in Eastern Lower Saxony, where I used a Siemens Modularis Variostar. That's another big device, but I left it because the treatment with that device was too painful for my patients. With my Storz devices, so electromagnetic generated shock waves, it's possible to treat each patient without any anesthesia. So I need a big device for long bones and a smaller office device for all those bones and fractures which are more superficial under the skin, like hand indications, foot indications, maybe the clavicula or the jawbone or something like this.
And so for people like myself who have a radial device from Storz and also a focus device from Storz, you would feel that doing the superficial bone tissue might be a possibility, but for long bones and also for the accuracy, really we must have imaging, number one, but also for the long bones we need this much bigger device where, like the computer game, we can zero in on the gap and purely treat that. Is that fair to say?
Now, you need, if you have a long bone in a depth of a couple of centimeters, so you have to focus the middle of the bone marrow space. So and maybe take as a good example a femur neck non-union and a guy which has a 90 or 100 kilogram. So you need a special distance from the skin surface to the middle of his hip is maybe 12, maybe 18 centimeters, depending to the direction from where you come. And it's completely impossible to use an office device with a maximal depth of 6 to 7 centimeters. You won't reach the middle of the bone marrow space in the gap. So you need a big device that is to treat long bone unions with smaller devices. It's impossible, cannot work. But for all these more superficial located gaps at the forearm or at the ankle, for example, or the midfoot, use these other devices, office devices, with electrohydraulic or electromagnetic generators, but don't use those with piezoelectric generators, because that is not accepted by the rules of ISMST, so our worldwide scientific society for shockwaves. They have a special recommendation concerning the prerequisites of shockwaves, and they are very clear in their order to use electromagnetic or electrohydraulic devices.
Very, very clearly put and understood. I like that. So if we could go one stage forwards now and talk a little bit about the physiological changes. So when you get your focus shockwave and you get it in the gap, and we're now delivering shockwave in the right space at the right depth, what's happening in that area there? What's taking place that makes...
Oh, that is... it's tricky and a little bit complicated to give a clear explanation, because all our researchers, they are common in their opinion to say we don't know each detail, of course, but it is possible to take measurements in bones of animals, for example, or dead persons. Researchers put an endoscopic machine inside of the bone, at the level of the gap, and then shockwaves came from outside, and they can measure the difference in energy flux density between the machine and the dosage in the bone. So it is possible to make measurements inside of a fractured bone or a bone with an osteotomy, for example. So to our comprehension, we do mechanical shock waves in a high dosage. High dosage means high energetic. High energetic means more than 0.45 millijoule per square meters. This energy flux density is high energetic, and for bones we need that. We cannot work with middle energetic shock waves. So these shock waves have a mechanism in the soft tissue, but it's not a destruction of any structures. You know, urologists, they use shock waves just to destroy kidney stones, but the work mechanism in the level of the bone marrow is completely different. It's only for regeneration. So the signal from the shock waves administered to the bone level, to the bone marrow, leads to several subsequent metabolistic pathways, and it goes to the production of osteoblasts, for example, and in the end you have the bone repair via ossification. But between your shockwave impulse and the ossification, the completely bone repair, is a big quantity of metabolic pathways and signals, and something like angiogenesis and the production of bone growth factors and so many other substances which work together to fulfill the target of the task of the bone to repair his fracture. So to our comprehension, these pathways are well understood, not completely understood, because it is not possible to have a proved measurement of each pathway as I understood it. You know, I'm a user, I'm not a researcher, and all my answers to your questions is that what I learned from others and our people from basic research. They try to identify all these combinations, the completely cooperation between different signal pathways in the soft tissue.
I have a question that comes off from what you were saying there. So if we have a bone non-union, then what is different about the fact that that bone is no longer healing itself, that means that Shockwave takes over and does that? So you've spoken about osteoblasts and the creation of new bone tissue and calcifications. Has the body just stopped working?
Yes. The good question, and that I come back, or I come to the definition. So look to the whole quantity of fractures each year in a certain country. Maybe in Germany we have 100,000 fractures. Will heal with the adequate treatment, like internal fixation. And after 8 weeks, or maybe 16 weeks, depending to the bone and to the type of fracture, doctors see a complete healing with complete stability. But maybe 5 to 10, and in some cases 20% of these fractures show an impaired healing. And after a couple of weeks, when the responsible surgeon identifies this fracture as a fracture treatment is necessary, then it is defined as a delayed union healing. And then you regard it for a couple of weeks, and after another 3 months, for example, nothing has changed. So the X-ray after 3 months shows an unhealed situation, and after 6 months again, that's a non-union. So non-union means pseudarthrosis. Here you have to act. It is necessary to do anything because nobody thinks to wonders. Doctors have to do anything. Otherwise, this fracture will not heal. And so we have delayed unions and we have non-unions. And if you go back to the beginning after fracture and you have a situation, for example, an open fracture with a wound infection and a big soft tissue damage, for example. So you have so many complications, maybe in combination with common risk factors like diabetes, or local risk factors like instability of the internal fixation. This is a fracture at risk. And maybe the traumatologist decide very early to adjust any other treatment like shockwaves or ultrasound, low pulsed ultrasound or electromagnetic field, whatever. So that is each bone, each fracture, each healing shows another progression, and the responsible traumatologist should decide for the best moment for additional treatments.
So, and that's perfectly clear for me. Thank you. I actually, during your webinar, I asked a question that was centered around, if Shockwave does such a good thing for a bone that has ceased to heal itself, then is it not possible that it could speed up the recovery of a new fracture? And you answered very well, but I think just to keep it within the confines of this, it would be nice just to put it all together, if you don't mind answering again.
Yes. If I understood your question right, you asked me if it's possible to treat a fresh fracture with shockwaves just to optimize the stages of healing.
Yeah.
Yes, maybe it's possible, maybe, but the ISMST has a very clear recommendation. They don't like to push this treatment for fresh fractures, which look not complicated, which are simple fractures, where everybody has the opinion that they won't see any complication. So maybe if you treat those normal fresh fractures, you could improve the healing, or you could increase the time for full stability, but that is not proven. And so it's not recommended to do so. But I understand your question. Maybe you have someone who is a professional soccer player, or those people where their body is their investment, for example, as a capital. Yes, maybe it could be helpful, but that's not science. It's maybe best practice, but not it has no scientific background. And I wouldn't do so, because my patients are carpenters, or those or normal people with occupational or private injuries, and commonly they have someone who pay this treatment, so any health insurances or accident insurances. And for me, it's not necessary to do so. And sometimes if other colleagues ask me, could we improve the healing of these special patients, I decide yes or no. And if there are no contraindications, sometimes I do so, but that is not the rule. The rule is that I make this indication together with those who were responsible for the surgery, and then we decide together to help him or her with shockwaves or not.
No, it's a good answer. And just to, I guess, to wrap this up, because we've had some connection issues, but the information has been fantastic, is to understand what you might feel about stress fractures. We in sports medicine, we see a number of stress fractures.
Sure.
And the key is to get these people back quickly. And anecdotally, I believe that we've seen some really, really good responses to tibial stress fracture, metatarsal stress fracture, and calcaneal stress fractures through using focused shockwave, high energy. What are your thoughts on that as a process?
Yes, I have enough patients with those insufficiency or stress fractures. And the ISMST has guidelines concerning these stress fractures, guidelines by Wolfgang Schaden from Austria. He has the best experience, I think, and others too. And stress fractures are a clear and good and approved standard indication for focused high energetic shock waves. The difference to traumatic fractures, for example, is the fact that you use only one single treatment. It's necessary, one single treatment. And maybe those other fractures need 2 sessions, maybe 3 sessions. That depends to the type of fracture, for example, and to the bone where the fracture is. But stress fractures need one single treatment. And this is a very successful indication. So a successful treatment and has a good indication. And so we have many, people who dancers, for example, or runners who have stress fractures. And here in Hanover, we have the Hanover Marathon. And each springtime in February, when the athletes come, some athletes with where their training was too hard and they have these stress fractures, and then we have more to do with this indication. And the rest of the year is more calm concerning this
Yeah, it's the same for us too. This has been truly inspiring, and actually the information has been fantastic. Frank, if our connection allows us, one of the reasons why I love to do these types of talks is because people don't always get from around the world to make it to things like the ISMST conference, or to engage with key opinion leaders such as yourself. And as an allied healthcare professional, I'm a physiotherapist. Sometimes there can be built up in people's minds a barrier between, you know, them and us. And so I like to ask a few questions like, what does Frank do when he's not being a bone specialist Shockwave user? What are your hobbies and interests outside of this?
Oh, I have many hobbies. So I'm a runner, for example. I finished 25 marathons and ultra marathons. And this year I was in preparation for Hanover Marathon, but of course canceled like all other sporting events worldwide. Then I play tennis. I like to travel. I looked to many countries in the whole world, and I worked and studied in different countries and different continents. And so that's my love to travel. Couple of times each year I like to visit Africa and Asia and South Africa, but also the European mountains in the Balkan, for example, or Russia and Caucasus. So there I'm very busy. Then I have three boys. Everybody is adult. They left us, so I'm here alone with my wife in our flat in Hanover, and we try to enjoy the life and to find a good work-life balance. That is not always very easy, but we try to be successful, and we improve ourselves each year.
Ah, fantastic. So last question, and it's one I like to ask everyone. What's number one on your bucket list of things to do?
In a professional way or in my personal life, or both? What do you think?
Both.
Both. Okay. This year I had the plan to get the certification as a tennis trainer, tennis coach. And I had my first courses this year. And now it's interrupted by Corona, unfortunately, but I hope to complete it this year. And next year, I start to give tennis courses for little children in our club, where I am responsible for for everything what has to do with the sports activities. And the other thing I do, I started to work as a fundraising manager in our club. So I try to get money from companies and from foundations for our sports club, where I play tennis, but we have many disciplines, and just to introduce the work with children and young persons in our club. So give them more better coaches and more educated coaches, more devices for sports. So that is my plan for the next 2 years. Idea.
Yeah.
Before we finish, I forgot a very good. I would like to tell you and the auditory a good history concerning shockwaves. So in the beginning, I reported about my second lecture here in Hanover, where Wolfgang Schaden from Austria came to Hanover to support us in our activities, and that was very successful. So at that time, 2005, I cared for shockwave treatment since 4 years, for example, and I had a certain understanding of this subject. A certain understanding. Then I picked Wolfgang up at the airport Hanover, and with my small car, we went to Hanover town. I brought him to his hotel, and these 20 minutes with him in my car showed me much more perspectives to shockwaves than all the years and the literature and everything else. So it was more important for me to speak with him 20 minutes, and that was gave a great input to me to understand more about everything what happens with shockwaves. And so if people ask me, I like to invite everybody worldwide to come to my office and to stay with me 2 days. And we treat 20 persons with shockwaves, maybe, if possible, if we have so much. And this is much more instructive for those people to learn everything, starting from how to get patients, how to make the indication, how to make the communication with the referring doctors, how to earn money with this, how to make your own marketing, and how to establish something like a competence center. This is very, very helpful. So if you find someone who likes to come to Hanover for a couple of days just to accompany me to clinic in my office and so on, so we can discuss, we can share our experiences, so everybody can share, and everybody is invited by me. And most guys who came, not guys, only women, were very happy to with their stay in Hanover. So this is my official invitation, and everybody could Google me, and then he will find my contact data. And this is, yes.
Frank, it's a wonderful, wonderful thing to offer. And I'm going to be the first one that's going to come. So I may have to slice this bit out until you've accepted me arriving before everyone else fills up.
Yeah, you're of course.
But
up to you.
Yeah, after me, only after me.
Okay.
I teach courses all over the UK and with Storts abroad, and I always offer people to come and watch me practice, because I wonder if people believe that I'm treating 10 people a day with Shockwave, and they wonder how these people are paying for this, and how do you make it work, because it is normal for maybe 1 or 2 or 3 people a week, not 10 people a day. So I say to them, I can teach you and teach you and teach you, but until you come and experience it. So yeah. My patients are very used to having somebody else in the room, because yes. I like to offer this out to people so they see how it's done. And you're absolutely right. Like your trip with Wolfie, you learned more in 20 minutes than you could do from 4 days of lecturing, which is my precise motivation to do these talks, because I could just ring you up and we could do this in private, but actually I believe in spreading this knowledge. I have the altruism within me is that I want more people to know and understand Shockwave as I do, and to grow at the same pace that hopefully I'm growing. So I thank you very, very much. You may have just frozen there again, I don't know. Are you with us?
Yeah. Okay. Yes. Thank you very much for this nice speech. And maybe we see again. And if you like to hear any other details, we can talk again. Okay.
Perfect. Frank, good. Thank you so much. It's been such a pleasure.
Okay.